और इसमें लेज़र पॉइंटर भी है. Okay, transverse and T's. So before I start transverse and T's, the worst result for acetabular fractures is in the T fracture. Least incidence of perfect reductions, but transverse fractures, you can fix them very well. Okay, and before we venture on to treatment of the transverse of the T or any acetabular fracture, it is nice and a great practice to have the bone model, to have practiced your approach, your planning, to have done everything that you want to replicate in the theatre. Beforehand, leave nothing to chance. Think of a very clear plan A, plan B, plan C before you take the patient up on the table. So that's the evolving. So what is a transverse fracture? We've all talked about this whole morning, and it's nice to get a repetition here because it only helps. So that's the hemipelvis. A transverse fracture runs transversely across the acetabular socket. And what does this transverse fracture do? It separates the acetabulum into an inferior ischiopubic fragment, and a superior iliopubic fragment. And what is the difference between a transverse and a T biomechanically? In a transverse fracture, you only have a transverse component. So there are two fragments. In a T fracture, the fracture line goes down to the opteroforamen, either perpendicularly or obliquely, anterior oblique or posterior oblique, which means that there are essentially three free fragments which separate from the main body of the ileum. So the iliac fragment usually has part of the dome, and there is an ischial fragment, and there is a pubic fragment. And this difference is important. It's extremely important. Why is it important? Anyone? Why is this difference important? Having a superior iliopubic fragment and an inferior ischiopubic fragment versus having three separate fragments with the dome as part of the iliac fragment. Why is it important to know this difference?
Ischial fragment, it's a free fragment.
These two fragments are free fragments. This essentially means that if you reduce a transverse fracture from behind, and there are three types of transverse fractures, it can be reduced from front or it can be reduced from behind. But what you do here is going to be transmitted to the opposite fragment. But what you do to the T fracture posteriorly will not get translated to the anterior fracture, and what you do anteriorly to the anterior pubic fragment will not get translated to the posterior fragment. And that is the reason why T fractures have the worst prognosis in terms of perfect anatomical reductions.
Sir, at this point, one small question, sir. If we have intact inferior pubic rami on same side and fractured rami fracture on opposite side, does it a variant of T fracture, does it have any problem with reduction?
Does it if it has a?
So right side having a transverse fracture.
Okay.
And left side he is having superior inferior pubic rami fracture.
No, not at all. The contralateral.
Contralateral.
If there is no disruption of the pubic symphysis as such, and it does not affect stability, the transverse will behave as a transverse. It is only when the hinge is damaged that it will try and become unstable, and even despite that, if it is a transtectal or if it is a juxta or an infratectal, it will be absolutely not a problem going from behind. If it's a transtectal, then you will need to go anteriorly instead of posteriorly. So diagnosing transverse fractures and T fractures, that is an algorithm which you practice every single time. When you take the patient up, you will be able to diagnose what your injury is. Dr. Puneet referred to it, and you will also be able to plan the approach. So we'll just run through it. the first thing, and we'll practice it on one of the cases here as well. So the first thing I need to see is the iliopectineal line intact. If the iliopectineal line is intact, that means there is no fracture going into the anterior column. So the only fractures present are those which extend into the posterior column, and these are the posterior wall, the posterior column, the posterior wall and posterior column. So the next thing on any AP X-ray that we are going to see, and 90% of all the fractures will be diagnosed on AP X-ray if you follow this protocol. So next thing we see is the ilioischial line, and ilioischial line is a statement of the posterior column. So if the ilioischial line is intact and the iliopectineal line is intact, that means the columns are intact. The only thing left to be damaged is the wall, right? If the ilioischial line is not intact, then you could have the posterior column damaged or a posterior wall fracture or a combination. On the contrary, if you have the iliopectineal line, which if it is not intact, that means you have definitely got a fracture which is extending into the anterior column, and the fractures which extend into the anterior column are anterior wall, anterior column fracture, transverse fracture, transverse with posterior wall, T, anterior and a posterior hemitransverse, and a bicolumnar fracture. Then you see the ilioischial line. If the ilioischial line is intact, that means there is no fracture going into the posterior column. The only fracture that you have is going into the anterior column. And what are these fractures? These are the anterior wall and the anterior column fractures, right? Now what is the difference in the two on X-ray? If you have a fracture which is going into the through the obturator foramen into the inferior pubic ramus, that's the third thing that you have to see always, obturator ring damage, so that you see the inferior pubic ramus. If your fracture goes into the inferior pubic ramus, that means that you have a column fracture, an anterior column fracture. If you do not have an inferior pubic ramus fracture, then you have a anterior wall fracture, right? Now a condition in which you have even the ilioischial line damaged, that is the iliopectineal line is not intact, ilioischial line is not intact. So my fracture is going into the anterior column and it has an extension into the posterior column. And what are these injuries? These are the transverse fractures which involve both the anterior and posterior columns. These are the transverse with posterior walls which involve both the anterior posterior columns. These are the T's, the bicolumnar and the anterior with posterior hemitransverse. And the next thing we see in all X-rays is the inferior pubic ramus, right? So if the inferior pubic ramus is not intact, is not damaged, then you do not have extension into the obturator ring, and the only fracture which will extend both into the anterior column as well as the posterior column without going into the obturator ring is the transverse fracture and the transverse with posterior wall. On the contrary, if you have damage of the inferior pubic ramus, that means other than the involvement of the anterior column and the posterior column, my fracture is going into the inferior ring, which means that if there is a spur sign, it's a definite both column. If not, then I need a CT scan, and the only two fractures which will need a CT scan for definitive diagnosis is either a T or an anterior with posterior hemitransverse, and that will help us to go into the, and just a look. Now in this patient, the iliopectineal line is damaged, right? The ilioischial line is damaged. That means both the anterior column is damaged and the posterior column is damaged. The next thing I see, is that the inferior pubic ramus is absolutely intact. That means that my fracture is going to the anterior column and posterior column, but it is not going into the inferior pubic ramus. The fourth thing that we will see is the iliac extension, but The only injury which will involve both columns without going in below is either a transverse or a transverse with posterior wall, right. So, the only thing left for us to evaluate here is if there is a posterior wall component also, right. All right. So, decision making, conservative versus operative, which ones do you conserve? What are the important criteria? If you have more than 10 millimeters of dome of the subchondral bone, and that is probably one of the most important things that we need to keep in mind in our reductions of the acetabular fracture. The head has to come back into a stable, come back beneath, congruently beneath a stable dome, and that is the absolute focus of all our treatments, whether conservative or operative. So, if you have more than 10 millimeters of intact subchondral dome, these are some of these fractures can be conserved. The next is the roof arc measurements, as Dr. Vijay alluded to. The third is that these fractures, do they have part of the femoral head which is congruent out of traction, and if there is less than 50% of the wall involvement in these patients. And what are the factors which are important in deciding what goes wrong with transverse fractures? One is that once you have a transverse component going in, the head tends to migrate medially, and with the migration of the medial head, there is a displacement of the transverse component. That is one. Second is that because of the medial migration, the head tends to impact on the sharp iliopubic fragment, which can tend to cause damage to the femoral head, and if that happens, it can cause or lead to early avascular necrosis in these patients. The third is the height of the fracture and the obliquity of the transverse component, and we will understand that as we come to the next slide, because there are three types of transverse fractures. So, the acetabular socket can get broken through the roof, which is the tectum, and this is called the trans-tectal fracture. So, the fracture line goes through the tectum, and these are the fractures which are most oblique, most difficult to reduce, and may need an alternative approach for fixation of some of these injuries. The other ones is that if it passes through the roof of the cotyloid fossa, which is a juxtatectal, or it passes beneath the cotyloid fossa, that is the, not beneath, but beneath the roof of the cotyloid fossa, that is the infratectal fracture. So, what are the important things in deciding the approach of a transverse fracture? One is the obliquity of the ischiopubic fragment. The second is the major displacement of the transverse component. And that was a fracture which was a, this is what kind of a fracture is this? Is it a juxtatectal or a trans or an infratectal? It is a transtectal, because it is probably going through the head, and some of these fractures require an anterior fixation, because the superior part is very oblique, because this superior part is very obliquely broken, and it is not always reducible through the standard posterior exposure, though most of the juxta and the infratectal fractures will get reduced and fixed from behind using the standard Cocker-Langenbach approach. And that is the types of fixations that you can get in your transverse fracture. So, this is a fracture which has been fixed from behind through the Cocker-Langenbach approach, right. So, these are the lag screws, and that is the transverse component, and that is the posterior fixation. The same fracture has been shown here. The plate is sitting dead centrally on the posterior part, and you fix the posterior wall fragment with lag screws. Sometimes if you have an extended posterior wall fragment, that means a normal posterior wall, as Dr. Ravi told us, is this, but if you have an extended posterior wall fragment, these fractures may not be very classically amenable to the standard Cocker-Langenbach, and in these cases you might need to use a trochanteric flip osteotomy to gain more access superiorly. And some of these fragments when they need to have a posterior to anterior screw, might need fixation with a trochanteric flip osteotomy as well. The position of the patient, you can use these, you can fix these fractures taking the patient posteriorly, laterally, or in a floppy lateral position if you expect to use both the anterior and posterior approaches. The problem is the difference between the lateral and the posterior exposure is that when you have two fragments, one is the ischiopubic and the iliopubic fragment, and your patient is lateral, then because of gravity the inferior ischiopubic fragment tends to sag, and reducing this fragment is sometimes not easy, which is easier when you do it in the prone position. But literature has shown that long term differences, there is a difference, slightly significant difference between the quality of reduction in prone versus lateral, which is better in prone, but long term functionality is not affected between the prone and the lateral exposure, right. So it basically depends on what you are comfortable doing. So once we have diagnosed, evaluated, decided we are going to operate, decided on the approach based on our algorithm, how are we going to expose the fracture, how are we going to reduce this fracture, and the reduction tools we will use. A very good tool is the Schanz pin, which we can introduce into the ischial tuberosity. This helps us to rotate the fragment either anteriorly or posteriorly and to manipulate the distal ischiopubic fragment very well. The other thing is that if you have a bone hook, this can help in the reduction because this fragment has a tendency to sag down, especially if you are using the lateral position. So you use a bone hook to pull this fragment up, reduce this, hold it with a clamp. If need be, you can put in your lag screw anteriorly and then neutralize it, either put a lag screw here as well or neutralize it with a buttressing plate. The other modalities of checking this reduction is that once you have reduced it, you put your finger, if I am posterior and this is how I am operating from behind, I can put my finger through the great sciatic notch and I can feel the pelvic brim in its entirety. And once I have a fracture, if here is the fracture and this is the ischiopubic fragment, that is the iliopubic fragment, and this fragment is going down, any step can very comfortably be felt by putting my finger into the quadrilateral surface. So if you put your finger into the greater sciatic notch, you will be able to feel what is the quality and accuracy of the reduction of your ischiopubic fragment to the iliopubic fragment, and that you can very safely do here. Now these are huge clamps and it is practically not always possible, though the AO literature shows these clamps very often, but quite a few times it is not practically possible to put these huge clamps into the pelvis. The young bluth, yes, but not always the large spikes, the smaller ones, yes. Another very important tool is the Schanz pin into the head of the femur, which helps you to keep the joint distracted and it will help the reduction of the ischiopubic fragment to the main iliopubic fragment as well. So you've approached your fragment, you've reduced it, your key instruments and implants. This is a very good tool. That's a Schanz pin with a T handle which can go into, it gives traction to the trochanter. You can use it as a joystick in the ischium, right. Then if you need to press down on any fragment, there is a ballpoint spike, which is a very good thing to have in your armamentarium, and it's nice if the hospital can afford for them to buy a pelvic set. These are the oblique reduction forceps. They come in different sizes and you can use the size that will fit well to your fragments, but this is your workhorse, the Wagner's reduction forcep, and this is a very useful tool along with these oblique reduction forceps in reduction and holding the reduction of most of your fragments. And then you need to have your bending forceps, which will help you to contour your plates, and the standard screws that you will use for a 3.5 set, right. What you will also need along with this is that you will need a large drill bit, a long drill bit, in case you need to put lag screws or the column screws which you might need to use for your fracture acetabular fixation. So before we go into surgery, you have to make sure that your team understands what you're going to do, you've discussed the plan with them, you have all the armamentarium on the table, and these are the screws that you will use, and these are column screws. So when I say iliopubic screw, the screw starts in the ilium, goes into the pubis, and this is a posterior to anterior column screw. Its direction is lateral to medial. It goes superior to inferior, and you have to be careful of putting this into the femoral neurovascular bundle, and the indications for them will be the T, the posterior column fracture, and that is how you will use the screw. You see if you draw a line going up into the iliac crest, this screw is almost 3.5 centimeters superior to the apex of the acetabular socket, and this is a screw which you will use in an obturator oblique position, and it will go from the posterior column into the anterior column, and it stabilizes the anterior part or the anterior component of the transverse fracture, right? And that's the direction of the screw. Fixation, there are certain transtectal fractures which you will need to fix anteriorly, or you might need to use an additional spring plate to seat the fragments in the greater part of the quadrilateral, in the superior part of the quadrilateral surface. But most you can fix, the juxta and the infratectal ones you can fix from behind using black screws. At the most you will need to use a trochanteric flip osteotomy if you have an extended posterior wall fragment along with it, and you might need to use a posterior to anterior column screw for fixation. And what is most important and what is different from the posterior wall fracture fixation and the transverse fracture fixation is that in the posterior wall fracture you underbend your plate, but in a transverse fracture you have to overbend it and over contour it so as to get a perfect reduction. If you don't do that, and if you leave your plate underbent, once you tighten the plate, your transverse component will displace anteriorly and you will not have a perfect reduction. So transverse versus T fractures, we have talked about this before, I will not repeat it again. Just a case example, that is a transverse with a posterior lip. Those are the 3D CT scans with which you can evaluate this fracture. That is the axial CT cut. This was a posterior dislocation which was reduced as in the emergency, and these are the post-operative images. But here also you will see that there is a marginal step in the posterior wall fixation, but this patient did reasonably well. So the complications, you may have a nerve palsy on admission in about 17 to 20% of these patients. Nerve palsies are often associated with dislocations. Iatrogenically, we might gift the patient a nerve palsy in almost 8 to 10% of the patients. Infections can occur in about 3 to 5%. Heterotopic new bone is especially seen in posterior approaches. So it's nice, it's a good practice to give indomethacin 25 milligram TDS for 3 weeks. And incidence of secondary OA in patients with satisfactory reduction is almost to the tune of 13 to 15%. Venous thromboembolism is a reality, and these patients, it can be seen in up to 60% of the cases. Sometimes it is non-symptomatic, but a lot of time it is symptomatic and it needs to be looked at and treated. So the essentials are, for a transverse fracture we need to have a meticulous initial assessment of neurology and tissue damage. An accurate diagnosis is very essential. We need to do a very rigorous preoperative plan, both the surgeon and the team, so that everyone on the table understands their responsibility and what they have to do. Identify the reduction approach, identify the strategies to be used, plan your lag screws, try practicing them on bone models, order any special implants if you need, plan your fixation strategies, especially your plan A and your plan B in case your plan A fails, and the aim is to get a perfect anatomical restoration every time. Thank you very much.